Okay, so there's many examples of glomerulonephritis. So if I was just to say glomerulonephritis, there could be 30 or 40 different conditions leading to it. But I think the most important thing is to understand what glomerulonephritis is. And it's inflammation of the glomeruli, whether it's from post-streptococcal or from other diseases. Okay, and here's another one called Goodpasture's syndrome or Goodpasture's disease, and it's an autoimmune disease that affects the kidneys and attacks the glomeruli, and also actually attacks the lungs. Okay, and patients with Goodpasture's disease typically have very rapid renal failure from their glomerulonephritis, and they cough up blood. They become short of breath. They have hemorrhages in their lungs because this particular autoimmune disease also is destroying the lung tissue. Okay, so how do we treat autoimmune diseases, including this one? Typically with immunosuppressants, right? To shut down the immune system from attacking itself. Okay, so when we were talking about glomerulonephritis, we were talking about inflammation of the glomerulus and a leaky glomerulus causing proteins to go across, red blood cells to go across. Nephrotic syndrome is not necessarily inflammation. It's just defined as a condition where you're losing at least 3.5 grams per deciliter in 24 hours in your urine. Okay, and that's a lot of protein to lose. In actual fact, you shouldn't have any protein in your urine, and 3.5 grams or greater definitely is telling us the glomerulus is leaky. So really, nephrotic syndrome is just defined by that, right? And there's many causes of nephrotic syndrome. That's not as important as understanding what nephrotic syndrome is, and that is defined as proteinuria of greater than 3.5 grams. Okay, so there's some kind of glomerular damage, okay, which leads to increased permeability of the glomerulus to larger molecules such as proteins, and 3.5 grams of proteins per 24 hours is a lot of protein to lose. So you're going to develop low protein in the bloodstream, typically low albumin in the bloodstream, and that's going to lead to edema, right? Reduced oncotic pressure. What's the other hallmark of nephrotic syndrome? Well, because your liver is sensing this reducing albumin level in the bloodstream, it decides to try and make more protein, okay? Make more albumin to try and keep up. But when the liver makes proteins, it also makes lipids, fats. So in the process of trying to keep up with the loss of the protein, the liver makes more protein, but it also makes fats, and you get hyperlipidemia. Okay, this is quite common in children actually. You can get it at any age, but it's relatively common in children. So let's look at the second point, hypoalbuminemia. Okay, so your albumin level is dropping in the bloodstream because you're leaking it out in your urine. What are the hallmarks of nephrotic syndrome? You have edema of your face, of your hands, of your legs. You often, and you have hyperlipidemia, right? You often actually have hypertension as well. Okay, so it's different than glomerulonephritis because it's not an inflammatory condition, and glomerulonephritis isn't defined by how much protein you're losing in your urine. But nephrotic syndrome is defined by how much protein you're losing in your urine. Okay. Now, because the body is the blood vessels are leaky. What happened, because they've lost their oncotic pressure, there's going to be a release of aldosterone, because there's so much edema in the body, but it's not in the blood vessels, it's in the tissue. And the blood vessels going to the kidney are saying, I don't have as much fluid in me because I've lost it all to the tissue. So that's going to stimulate renin secretion, which in the end is going to lead to angiotensin II production, and then secretion of aldosterone to reabsorb even more salt and water from the kidneys. So you're going to get even more edema and more hypertension in this condition. Okay, so nephrotic syndrome and nephritis, glomerulonephritis, both can cause hypertension. Okay, and remember, because you don't have any oncotic pressure, because of your low albumin in your bloodstream, you can be leaky all over the place. Not only are you going to have swelling all over your body, but you can start to have leaky blood vessels in your lungs, causing a pleural effusion. You can have leaky blood vessels basically anywhere because the albumin is dropping in your bloodstream. Foamy urine, whenever you have protein in your urine and you urinate, it's going to form a foam on top. So if you've ever had a protein shake and it's been mixed, you'll know that there's foam on top, and that's the protein. Okay, so when someone comes in and they say, I have foamy urine when I urinate, that's likely some protein that they're leaking into their urine. Okay, and here's some images of a child with nephrotic syndrome, right? So look at the facial edema, look at the lower leg edema, and that's from having lost all of this protein in the kidneys, right? From this very leaky glomerulus. Okay, so nephrotic syndrome defined by the amount of protein that's being lost in the urine. Glomerulonephritis, or quote nephritis, is inflammation of the glomerulus, causing a leaky glomerulus of protein, white blood cells, red blood cells into the nephron. Okay, so slightly different conditions and different diseases cause them. One's more inflammatory, the nephritis, and nephrotic is more based on protein loss. Okay, so let's look at this slide that compares nephritis or nephritic syndrome to nephrotic syndrome. So nephritic syndrome is the same as glomerulonephritis. Okay, so let's just say you have some condition such as post-streptococcal, those antibodies that attach to antigens and inflame the glomerulus all throughout the kidneys. And what's going to happen? Well, you're going to make less urine, right? Because the glomeruli are being harmed and they're inflamed. It's going to lead to hypertension. It's going to cause you to have dark urine or bloody urine, so cola-colored urine. The urine is going to test positive for protein. It's going to test positive for red blood cells. It could test positive for white blood cells if they leak across the glomerulus. Okay, so it's not a bacterial infection. It's inflammation of the glomerulus. Okay, and there's many types of glomerulonephritis. That's IgA nephropathy is just one example of where there's an antibody that's produced in your blood that directly attacks the glomerulus and causes glomerulonephritis. That's just one example. It is the most common, but it's just one example. And we used good pastures as another one, and post-streptococcal as another one. Okay, nephrotic syndrome, defined as losing more than 3.5 grams per day or per 24 hours in your urine. What's that going to cause? Well, so lots of protein in your urine. Do you have to have red blood cells? No. Do you have to have white blood cells? No. In your urine? Not at all. Protein. Okay. That's going to stimulate the liver to try and make more albumin, but in the process, it makes more lipids. So you have high lipids in your bloodstream, and we can test that. You have a lot of edema in your legs, in your hands, in your face, because of the loss of oncotic pressure. Okay? And you have massive amounts of protein in your urine. How do we test that? Well, if we pick up your protein in someone's urine and they have swelling all over their body, we're going to do a 24-hour protein urine test. So they're going to urinate into a container for 24 hours, and we're going to see how much protein is in the container after 24 hours. And if it's greater than 3.5 grams, then they have nephrotic syndrome. Okay, so let's talk about the concept of an acute kidney injury, right? An AKI. And acute kidney injury can be caused by an assortment of diseases or processes. So it's usually something that suddenly happens and there's a sudden decline in renal function. Okay, and we're going to break acute kidney injury into three parts. So something that's occurring before the blood gets to the kidney, so prerenal, something that's occurring within the kidney, intrarenal, and something that's occurring postrenal, after the kidney. So that's usually something to do with, say, the bladder. Okay, so prerenal, intrarenal, and postrenal conditions. And these typically occur when there's other illnesses that are happening in the body or an injury. And we'll come to an example in a minute. So what are indicators of an acute kidney injury? Well, your BUN, your blood urea nitrogen, and your creatinine go up. They become elevated suddenly in a matter of hours to days. BUN usually goes up faster than creatinine. Okay? Or you have a decreased glomerular filtration rate, which we measure as a creatinine clearance. Okay, so we can take somebody's creatinine, a serum creatinine, and then calculate a creatinine clearance, meaning how well are the kidneys filtering creatinine. And that is really a very close measurement to a glomerular filtration rate. Okay, so those are indicators of kidney injury. And if they occur suddenly, within a day or two, it's acute kidney injury. Chronic kidney injury is something that takes place over months to years. Okay, so let's use an injury. Let's use an example of severe vomiting and diarrhea. So there's an older patient that comes in, and they're 75 years old, and they've been vomiting and had diarrhea for the past 5 days. They haven't been able to drink very much. They're weak, and when we see them, we can tell that they're very dehydrated by looking at their mucous membranes, such as in their mouth. They have a fast heart rate of 120. Their blood pressure is, say, 90 on 60. And then we do some blood tests. And their creatinine is very elevated. Say it's 6 or 7 or 8. Their BUN is very elevated. Their creatinine clearance is markedly decreased. So what's happened? So the injury is because the kidneys haven't been perfused for days, right? They haven't been getting the proper blood flow. So the creatinine can't be excreted the BUN can't be excreted, and the kidneys, which aren't receiving blood flow, are now showing signs of injury, right? So when you have an acute kidney injury, your markers go up, such as BUN and creatinine. And they go up because there's just not enough blood flow in a pre-renal state to perfuse the kidneys. So dehydration, say a hemorrhage, anything that's pre-renal. Say you're septic, so you have bacteria from a pneumonia that's coursing through your blood, and your blood pressure's low, and now your kidneys start to fail. Well, that's a pre-renal acute kidney injury, because it's something that's upset or disrupted the normal blood flow to the kidneys, which is usually hypotension. So anything that affects the plasma volume in a negative way, and it decreases blood perfusion or blood flow to the kidneys, is a pre-renal injury. An intrarenal injury is something that's happening directly to the kidneys. So let's say glomerulonephritis. Well, that's a direct injury to the kidneys, okay? So if we have someone who has, say, post-streptococcal glomerulonephritis, we would say that that's an intrarenal acute kidney injury that's leading to elevated BUN and creatinine, okay? What about post-renal? Well, how about an older man, such as 75 or 80 years old? I'm not going to use my age. And he has a very enlarged prostate, and he has difficulty emptying his bladder. And this has gone on to the point where now he's unable to urinate very much. He's just dribbling. And the urine now that's in the bladder has become quite significant. The bladder's distended, and there's backup of urine up the ureters. And now the kidneys can't produce any more urine. Okay, so BPH, benign prostatic hypertrophy, leading to a backup of urine into the kidneys, and making the kidneys unable to excrete any more waste, and to process the way they normally do. So that's a post-renal issue, right? So BPH leading to renal failure, acute kidney injury, is a post-renal issue. Say you have a surgery in your pelvis, and the surgeon happens to injure both ureters during a surgery. And now both ureters are blocked. They scarred up, they got blocked. And so both kidneys now can't take their urine to the bladder, and the urine's going to back up to the kidneys. The kidneys are going to go into acute kidney failure. And so that is an example of another post-renal acute kidney injury. Okay? And you would still have elevated BUN and elevated creatinine and a decreased creatinine clearance. So it really just depends on what the cause is. Okay, so classifications of acute kidney injury that we just spoke about on the slide before. Let's consolidate it with this image. So a pre-renal issue is anything that reduces blood supply to the kidneys, whether it's hemorrhage or dehydration, anything that upsets the blood supply. And that could be an overwhelming sepsis where you're hypotensive. Okay? Intrinsic or intrarenal is a problem within the kidney. So any kind of glomerulonephritis, anything that's directly harming the kidney. So we could have used good pastures as a disease that's directly harming the kidney, or post-streptococcal glomerulonephritis, or say a nephrotic syndrome that's directly harming the kidney. Those are intrinsic to the kidney. And post-renal, we've spoken about that. Anything that blocks both ureters, or a very enlarged prostate, that's impeding the flow of urine out of the bladder and causing backup of urine to the kidney, leading to acute kidney injury. So pre-renal acute kidney injury is the most common because people become hypotensive for a variety of reasons, right? So someone who decides to go for a 10-kilometer run in the middle of summer and it's 103 degrees out and they haven't kept up with fluids, well, they're going to get dehydrated, they're going to have reduced blood flow to their kidneys, and the kidneys are going to respond with acute kidney injury due to lack of blood flow to the kidneys. So normally your kidneys take up 1/4 of your entire cardiac output. So 25% of all the blood that is pumped by your heart goes through the kidneys for filtration. Okay, that's an amazing amount. So, typically the renal cells or the nephrons can tolerate a certain amount of reduction in blood flow, let's say 25%, before they start to be harmed. Okay. So what's going to happen here? So there's hypoperfusion to the kidney. That's going to cause potentially a acute kidney injury, a pre-renal injury, but it's also going to trigger the renin-angiotensin system and ADH secretion to try and increase plasma volume. Okay, so that's an automatic trigger to try and increase plasma volume. So on top of that, the low blood pressure, say from hemorrhaging or severe dehydration because you've been so sick, is causing a low blood pressure. A low blood pressure is going to be sensed by the sympathetic nervous system, and the sympathetic nervous system is going to vasoconstrict your arterioles to try and maintain blood pressure. Okay, so when the sympathetic nervous system vasoconstricts blood vessels, it's vasoconstricting in the kidneys as well, because it's trying to maintain blood pressure in the whole system. In the main arteries, it wants to make sure that the brain is getting the blood and maintaining the blood pressure to the brain. So that's also going to lead to a reduced flow to the kidney and decreased urine output. So if your kidneys don't see good blood flow to them, well, they're going to reabsorb with ADH all the fluid. Aldosterone is going to reabsorb the salt in the water, and the sympathetic system is going to vasoconstrict, and all of those are going to result in reduced urine output. So if someone is very dehydrated, or if someone has had, say, some kind of a hemorrhage, such as a bleeding peptic ulcer, or they were in an accident and they were bleeding significantly, how do we monitor whether they have a good circulating blood volume? Not only with blood pressure and heart rate, but urine output. So if your kidneys are making urine, that's very reassuring. Okay. If you were in a car accident and you were hypotensive, and we're not getting good kidney urine output, it means that your body is keeping all the fluid still, and it means that there's not enough flow going to your kidneys yet. Okay. So if you have something that's untreated, such as low blood pressure, that's going to lead to poor perfusion or poor blood flow to the kidney. That's going to cause ischemia to the kidney. And ischemia is just lack of oxygen to the nephrons. That will result in injury to the cells of the nephrons, the tubular cells, and it'll cause acute tubular necrosis. So acute kidney injury. Okay, so that's how the process happens when you have poor blood flow to the kidney. That the nephrons are saying, I'm not getting enough blood flow, so I'm going to start to shut down. And your creatinine is going to go up, and your BUN is going to go up. Okay, so what can cause pre-renal acute kidney injury? Well, we've spoken about a number of things, but anything that reduces blood flow to the kidneys. So let's look at some things. Hypovolemia. So anything that reduces your circulating blood volume. That could be dehydration, that could be a hemorrhage from an accident, hypovolemic shock. Hypovolemic shock is basically another term for I'm bleeding, I'm hemorrhaging. Sepsis causes hypotension, so that could lead to an acute kidney injury. Any kind of trauma where you've bled a lot will also lead to hypovolemia and acute kidney injury. So it's all about the blood flow to the kidney, okay? When we're talking about a pre-renal injury. What about cardiovascular disorders? So say you had a heart attack and your heart stopped. Well, the blood flow to the kidney is not going to be good. What if you have some kind of really unstable arrhythmia of the heart? Well, the blood flow to the kidney is going to be poor. What if you have congestive heart failure and cardiogenic shock, meaning your heart is dying and your blood pressure is severely low? That's going to result in poor blood flow to the heart. What if you're on a whole number of blood pressure medications to reduce your blood pressure and your blood pressure has become too low? That's going to reduce blood flow to the heart. And we mentioned sepsis, right? Which is going to reduce blood pressure to the heart. So they all come to the same answer in the end: reduced blood flow to the heart. Okay, so what does the kidney do under these circumstances when there's reduced blood flow to the heart? Reabsorb sodium and water due to aldosterone secretion to try and increase intravascular volume, okay? And by trying to reabsorb all this fluid back into the bloodstream, the urine output decreases significantly. So we can tell if someone is starting to recover from acute kidney injury when they start to produce urine, right? The kidneys start to make urine, which is a very good sign that their blood pressure is good and that their kidneys are recovering from the acute kidney injury, which in this case is low perfusion to the kidneys, okay? Now, when you have acute kidney injury that's from a pre-renal cause, the BUN is usually higher than the creatinine. I know they're both markers of the kidney, but remember, when you have poor blood flow to the kidneys, because the BUN, the blood urea nitrogen, is made much faster from the breakdown of amino acids, it climbs much faster when it can't be excreted by the kidneys compared to the creatinine. Okay, so if you have a ratio where the BUN over the creatinine is greater than 20:1, that's a very strong indication that it's a pre-renal cause that's leading to this acute kidney injury. Okay, because the BUN can't get excreted by the kidney, and it goes up very quickly in the bloodstream. Okay, what's the treatment for acute kidney injury from a pre-renal cause? Intravenous fluids, potentially blood if someone's hemorrhaging, anything to improve renal perfusion, right? So whether that's IV fluids or IV infusion of blood products, whichever one gets the blood pressure back up. Okay, let's go to the next topic, intrarenal acute kidney injury. So something is directly harming the kidneys that's now leading to kidney injury, Okay, so it's often damage to the filtering structures, which are the nephrons, right? So whether the glomerulus or the tubes of the nephron, and what can happen is you can get acute tubular necrosis, meaning something has happened within the kidney and the cells that line the tubes are now injured or dying. Okay, acute tubular necrosis, ATN. So what can cause that? Well, toxins can cause it, such as nephrotoxic drugs, and ones that come to mind are aminoglycosides. Vancomycin can cause intrarenal injury or intrinsic kidney injury. And really, it's death of these tubular cells, and they slough off and go into the urine, right? Acute tubular necrosis. So when they slough off, they go into the tubule, and they can form casts, right? And they can block up the tubules and lead to obstruction of the nephrons and oliguria, right? So when we spoke about oliguria in prerenal, it was because just not enough blood flow. In this case, the oliguria is because the nephrons are being directly harmed by a drug or by something that's directly harming the kidney. So let's look at the causes. So acute tubular necrosis, we can't really call that a cause. That's the result of something that's harmed the kidney. Okay, so let's go to the next one, glomerulonephritis. So any kind of an autoimmune disease, such as Goodpasture's, any kind of glomerular injury will lead to acute kidney injury. That's intrinsic to the kidney, post-infectious streptococcal. Lupus, right? So lupus directly hits the kidney with antibodies, and it can cause lupus nephritis, right? A glomerulonephritis from a condition called lupus. Kidney transplant. So someone who's had an organ transplant, in this case being a kidney, and the body now attacks or rejects the transplant, that's a direct injury to the kidney. Okay. What else can cause it? Well, there's many drugs that can injure the cells of the nephrons. So NSAIDs are a huge one, and we'll just add aspirin to the NSAID group, the non-steroidal anti-inflammatories. So we always need to check a patient's kidney function if they're older, if we're starting them on non-steroidal anti-inflammatories. Furosemide, which is a diuretic, but it's nephrotoxic. Vancomycin, nephrotoxic. Aminoglycosides, nephrotoxic. IV contrast that we use for CAT scans can be nephrotoxic. Okay? So anything that directly harms the kidney, we will call intrarenal acute kidney injury. Okay, so this is a list of nephrotoxic medications. I would not even begin to try to memorize it. Okay, please don't. There's no need to memorize this list. It's in nursing manuals. It's in textbooks. It's on a computer. So don't fill your mind with memorizing this. But this is just an example of how many nephrotoxic medications there are out there, right? So some of them you've probably learned about in last semester. So amphotericin B I see on there. I see lithium on there, which is nephrotoxic. Ketorolac, that's just a non-steroidal anti-inflammatory. Ibuprofen should be on there. Again, another NSAID. Gentamicin is an aminoglycoside. What else do we have on here? Tobramycin is an aminoglycoside. There's vancomycin, which is an antibiotic. So just examples of drugs that are really hard on the nephrons and lead to acute tubular necrosis and kidney injury that way. Okay. Okay, so let's look at these conditions and ask ourselves whether it is pre-renal or intrarenal. We haven't spoken about post-renal yet. So what about blood reactions? What about a hemolytic blood reaction where someone gets the wrong blood type and they have massive hemolysis, so breakdown of red blood cells from the reaction, and they likely have hypotension, right? So is that pre-renal? Is that intrarenal? Well, there's going to be a pre-renal component because they're going to be hypotensive, right? And that's going to lead to decreased perfusion to the kidneys and a pre-renal acute kidney injury leading to increased creatinine and increased blood urea nitrogen. But there's also going to be an intrarenal component to it because all the breakdown products are, of all these cells are going to clog up the kidneys, right? They're going to clog up the glomeruli and harm the glomeruli. So I really think that there's an intrarenal component to an acute blood reaction. What about sepsis? So sepsis typically has significant hemodynamic changes. So patients' vital signs are often abnormal with hypotension, tachycardia. They often have an increased respiratory rate. They have decreased urine output because they're hypotensive, so the kidneys are trying to reabsorb all the fluid they can. So this is really a pre-renal problem, right? What about burns? So burns lead to extensive tissue edema, fluid loss out of the intravascular space, and it'll be pre-renal, right? Now, can you have an intrarenal injury with burns too? Sure. If you burn, if you have significant burns of cells, all those products of metabolism that are in cells, and say you've burned through muscle as well, they're released into the bloodstream and they clog up the kidneys. So myoglobin, CK, which is an enzyme in muscles, they can clog up the glomeruli and lead to an intrarenal injury. Okay? What about trauma? Well, trauma is usually a cause of hypotension, decreased perfusion because you could be potentially hemorrhaging. So that would typically be a pre-renal injury by itself. Okay, so I hope that makes sense. It's not always absolutely one, pre-renal or intrarenal. Sometimes it's a combination of both of them.